So this was a nice study that was from a practice in rheumatology that did a lot of consults for ANAs. And they, in 1 year, they had 232 consults for a positive, quote, positive ANA, which they received as even as low as 1 to 40. 80% of them were from primary care. And of those 232, only 9% actually had an ANA positive rheumatic disease. And as you can see from that, almost all of them were greater than, or at least one was 1 to 60, but most of them were greater than 1 to 320. And when they looked at them, the ones that had rheumatic disease, of which there were about 23 of them, they were usually high titer ANAs. All the other rheumatic diseases, not necessarily autoimmune, but rheumatic ones, were low titer. So they had some RA, they had some crystal arthritis, some PMR, some vasculitis, some seronegative arthritis. None of these are characteristically positive ANA disease. And then they had a bunch of non-rheumatic diseases, and 28 of them had thyroid antibodies. And so there's a lot of overlap of thyroid antibodies with ANAs, but actually 4 of them only 4 of those 28 had known hypothyroidism, and 1 was a new hypothyroid. But what all the other ones had, as you can see, was a long list, and this is the kind of list that we frequently get when we go around the room. And most commonly is what we see an awful lot of is widespread pain. So in 23% of them, fibromyalgia was the actual diagnosis in those patients. Some of them had some other diagnosis. Another 9% had hand pain, of which osteoarthritis, some carpal tunnel, some other arthritis was concerned. A bunch had knee pain and chronic back pain, most of which were OA and some regional pain syndrome. They did have 5 patients with headaches that just had headaches, and then some other non-specific ones as well. So the prevalence of ANAs in healthy people or with other diseases is really very common. Up to 23% of healthy individuals may have a positive ANA, and it's age dependent, and I'll show you some very recent data from the NHANES study, but it can be just in healthy people over 65. Infections cause positive ANAs, most commonly infectious mono, TB, all the HCV, the viral illnesses, subacute bacterial endocarditis is another one that's typical. And then there are a lot of medications, not only the ones that we know that cause actually lupus illnesses like procainamide, anticonvulsants, hydralazine, minocycline's a common one, some of the anti-thyroid antibodies, but also some ones that we don't think of as much, diltiazem, rifampicin, INH, lithium, and then of course the TNF inhibitors that we use for the treatment of RA can also cause positive ANAs. So this is the study from the NHANES study. So the NHANES is National Health Assessment, something anyway, it's done almost every 10 years, and these are 3 time periods. The first one, if my arrow can go, is from 1990, around 1990. They collect data from 14,000 US individuals every 10 years. This is 1990, 2003, and this most recent one was 3 years around 2012. But it was, as you see, just published this year. And the ANA frequency overall has gone from 11% up to 16%. And it's not unexpectedly more common in females, so up to 20% of all females, this is not just older people, are positive, and it's up over 11% in male, and both of those were significant. Age, it increased significantly in the younger age group, the teenage years, as well as the older age, over 50, with more than, not 65 anymore, but over 50%, I mean over 50, 20% had it. And race, it was very common in African Americans also, as well as Caucasians, but interestingly, Mexican Americans in this population were less common. So they looked at some basic information. This is increased in most groups, but it really wasn't very meaningful because it was in overweight, but not really statistically significant in obesity. It was highest, actually, interestingly, in non-smokers and non-alcohol drinkers, so that their exposures to the things that we think of that might produce something or other that might cause a positive ANA did not show up in this NHANES population. Of course, it's not really able to detect all the other kinds of exposures. There was a significant increase with secondhand smoke, which I thought was interesting, but interestingly not with active smokers, and only with moderate drinkers. So it's hard to interpret those exposures. So these ANAs can be seen in many other diseases, but it's really not diagnostic. And so in as many as 30 to 50% of RA, a quarter of multiple sclerosis, very common, as I mentioned, in thyroid disease, in some of the other autoimmune things like ITP, discoid lupus, again, malignancies, fevers, even breast implants, and even fibromyalgia get positive ANAs, but it's, again, not diagnostic and it's not particularly helpful. Also important is that many relatives of patients that have autoimmune diseases, why is it doing that? Autoimmune diseases such as lupus or scleroderma will have a positive ANA just because they're a relative. And that's a very common finding in the ANAs that we see in our clinic, is that some other family member has one of these autoimmune diseases, and so they have a higher increase of having a positive ANA. So how is an ANA test done? And this has been increasingly challenging because there are lots of newer methods that we will talk about, but the gold standard is using an immunofluorescent method using the HEP2 cell lines. And with this method, you can get titers of ANAs and you can get patterns. But I'm sure many of you have seen the direct ANAs and the ELISA ANAs that don't give us either of that information. And so it's increasingly challenged. The patterns of the ANA can give us clues, not diagnoses, but clues to diagnosis. So the RIM pattern, and if you have a good lab, they'll give you the actual pattern, and it's reliable. It's not always reliable because depends on the technician looking into the microscope, looking at what the pattern is. So the RIM is significant for anti-DNA. The homogeneous pattern, a lot of people think of it as DNA and lupus, but it also is associated with an SCL70 and scleroderma. The centromere is the classic centromere that we see in limited scleroderma. And the nucleolar pattern, it can be associated with scleroderma or with liver disease. That's a common antibody that's seen in liver disease. So these are the different patterns that you can see. And this is the homogeneous. The staining is very homogeneous. The nucleolar, you can see these much larger speckles here. They're not really speckles, they're just larger amounts of deposits there. And then the rim is obvious there. And here is the fine speckled. And some of the ANA experts will really get into very, I think they can come up with as many as 20 different actual patterns, whether there's fine speckled or big speckled or whatever they do. But these are the sort of the main ones along with the centromere pattern, which can, stop doing this. which can be confused, but if you look here, when they're in telomere and dividing here, you can see that's the classic centromere pattern. And that usually you see, as you can see, in a lot of these all lined up there, and that's what the centromere is. So these newer methods, the ELISA assay is very easy to perform. It's cheaper, but it's less sensitive, doesn't give you the pattern, and it's just harder to interpret because of that. And then there are these multiplex bead assays. So they put the antigen onto a bead, and then they run it through a computer, and they just spit out the information. It also has a lower sensitivity, again, inability to get a picture or a pattern, but it can be very useful for very specific antibodies because it does, they do have antibodies for all of these other antigens there, and so that can be helpful. But there are problems because they don't pick up all the antigens. So this multiplex assay is often called a direct ANA when you order it, and many of them, so we've done a study, and it's been done in lupus, where if you do this in known lupus and scleroderma patients, you could have as many as 40% of patients with negative ANAs. And when you do it with an immunofluorescent ANA, they're positive. But also there are a lot of false positives, and we're now getting a lot of consults, again, because someone does this direct ANA and they come up with an SSA or a DNA or an RNP or an SCL70. And yes, it causes a referral to rheumatology, but most importantly, many of them, if they're just a low titer, or not titer, a low number, it's usually a false positive. So this was a study out of Duke, where they looked at 100 known lupus patients, all of whom had had positive ANAs by at least one method, and they found, as you can see, many, many negative ones here, and even different immunofluorescent kits and different technicians, they can find patients that had negative ANAs, and 11 to 13 in this study. Other studies have been higher, have been negative. So when should you order an ANA? Most importantly, you want to order it in order to try to establish a disease in a patient that has clinical features suggestive of a connective tissue disease. Or if you have a patient with not a lot of classic information, you want to exclude it. So the list of features that are suggestive of connective tissue disease is long, and you can think of all of them, and we're just going to go through some of them to emphasize how you should use these symptoms to either consider a connective tissue disease and order an ANA. So first of all, inflammatory arthritis, arthralgias. Remember, this is usually swelling, usually bilateral, morning stiffness, knees, wrists, and fingers are most common. And so if you see a patient like that, and even if they don't have obvious swelling, if they have this typical bilaterality and morning stiffness, and remember, morning stiffness is not just the 10 or 15 minutes when an older person gets up and walks around, and it's really a good hour to 2 hours that morning stiffness lasts. And so in that group of patients, you should order your blood count, your ESR, your CRP, your rheumatoid factor, and your ANA. And that's a good screen for someone. If the ANA is positive, and I consider officially an ANA that we used on that NHANES study was 1 to 160. I think greater than 1 to 160 is more likely to be meaningful. And if you think that this arthritis is maybe related to lupus, you can go ahead and order your DNA, your complements, your urinalysis, and your ENAs, the SMRNP, SSA, and B. And then if you are concerned about it not responding to treatment, then you can certainly refer to rheumatology. The biggest issue in pain is that it's very difficult for many patients to characterize. Most of it is more than just joint pain. Most of it is muscle pain. It's all over. It's commonly associated with poor sleep, and yet it's not just morning stiffness. They just have pain all day long. And these patients usually have a very positive review of symptoms, but don't forget to get the history of sleep, because these patients inevitably will tell you that they have difficulty falling asleep, awakening, and not going back to sleep. They also have a lot of jaw pain. Remember, TMJ is different than jaw claudication that we see in PMR and vasculitis. Headaches they have, irritable bowel, heartburn, diarrhea, constipation. They really have a lot of all of these symptoms. They also have cognitive dysfunction and difficulty thinking. Many of them call it fibrofog. They also have a lot of nerve complaints. Very commonly, they have paresthesias and burning pain, and just a whole slew of different symptoms. And as you know, fibromyalgia doesn't have a nice blood test that we can do. It's really a clinical syndrome, and it's a constellation of all these symptoms. But many of them are sort of lupus wannabes or disease wannabes, so they will, if they get a positive ANA, they're going to hang their, they're really going to get excited about that they have a real disease, since so many people if they've been told in the past they have fibromyalgia and it's all in their head, it's very frustrating. Fibromyalgia is a real disease. It has lots of problems and lots of difficulty managing it, but it's not associated with a positive ANA. So you check these things only if the ANA is really positive, or if your inflammatory markers are really elevated, or your rheumatoid factor is positive, would I suggest that you refer to rheumatology. But most rheumatoids will have, in addition to having a positive rheumatoid factor, will also have more localized joint swelling with inflammation and morning difficulties. If you're trying to treat your fibromyalgia, the most important things is to try to get them improved sleep. You can try your good sleep hygiene and over-the-counter things. I use a lot of Flexeril or cyclobenzaprine as a nighttime aid to help with sleep, and then encouraging aerobic exercise. There are medications that are approved, Cymbalta, Lyrica, Savella, and then if depression is part of it, using antidepressant. But this is a very difficult problem, because it takes so much time to deal with them. And the last thing we want them to do is to get treated with steroids because somebody finds a positive ANA and makes the diagnosis of lupus. And I can tell you that many, many, many patients get into that situation and have all the toxicity of steroids when they really never needed it, and usually don't even respond to it. So there are other kinds of pain syndromes. A lot of them are localized, a lot of them that the rehab people call myofascial pain with localized problems in the back and the hip or hand. And usually those are much easier to determine that are not inflammatory. So consider osteoarthritis. They may just have a regional pain syndrome, but would get x-rays. Again, check your inflammatory markers. Also check your thyroid, because a lot of thyroid patients have a lot of increased difficulty with pain. And you can treat them with Tylenol or NSAIDs depending on their other medical problems. And physical therapy is a very important part of management of pain syndromes. And I really encourage you to use our physical therapists, which are excellent. If you then don't have any response, then I think you can refer to rheumatology and see whether we have any additional ability to help these patients. So headaches. Headaches are another one of these issues that are commonly very frustrating to primary care people, but they're rarely related to ANA diseases. So don't check an ANA just because somebody has a headache. In an older person that has new onset of severe headaches, particularly if you can get a history of morning stiffness with polymyalgia rheumatica symptoms, remember that's not weakness, but it's pain, or that they have jaw pain, such as jaw claudication. Though if their SED rate is over 40, then clearly this is a patient that needs to be referred to rheumatology to make the diagnosis of PMR. If it is normal, then, if everything checks out, just go ahead and treat the headaches as you would any other patient. There is a very good neurology headache program here, and so they have lots of things, including Botox and all kinds of other treatments that they use nowadays. So that's a good resource as well. So myalgias, there's a lot of patients that have muscle pain. But remember, myositis is most often muscle weakness without pain. So don't assume that this is going to be a myositis just because they have muscle pain. Polymyalgia rheumatica does have a lot of muscle pain, but it's proximal muscle pain and stiffness, particularly this very classical morning stiffness that improves after a couple of hours. And again, it's usually both shoulders and hips. A lot of patients that have just proximal shoulder may have neck. Cervical spine often mimics degenerative arthritis, and cervical spine will often mimic the proximal shoulder. So make sure you check neck x-rays in that group of patients. But if they don't have this prominent morning stiffness and an elevated inflammatory markers, it's not likely to be a PMR. So in this group of patients, you can go ahead and check your CPK and aldolase and inflammatory markers, but I wouldn't check ANAs. Myositis ANAs, yes, they can be positive, but remember the myositis panel is a whole very unique set of antibodies, and most of them, I don't know about most, but certainly many of them do not have an overlap with positive ANAs. So rashes, I think this is one of the most difficult areas for primary care and for internists, is because there's so many different kinds of rashes. The classic autoimmune rash is mostly photosensitive. The malar rash is definitely photosensitive, but it is often confused with rosacea. And remember that lupus, the malar rash, spares the nasolabial folds. I think I'm going to show you that. And you can see here that the lupus rash spares this nasolabial fold. That's not something you can really easily get by history, but certainly if a patient comes in with a malar rash, you can see that. Other rashes, certainly consider referring to dermatology. Dr. Christine DeWitt is the med derm person that we use frequently, but there are other ones that go to the wound clinic. Megan Catton-Fader is an excellent nurse practitioner in the dermatology practice, and she can do a biopsy and treat a lot of common problems. So if you're having difficulty getting patients into dermatology, please work with that group of patients. They had been on the 6th floor with us in room derm, but then they moved down to the 4th floor into the surgical, and now I'm not sure they're in Georgetown yet because of the COVID, but hopefully they will be back on site soon. So the important thing, we talked about this as far as the nasolabial folds. Rosacea often has more papules, again, but the important thing is photosensitivity, and patients are very easily give you that history. So then when you get other types of organ involvement, proteinuria, if you have someone that has some proteinuria, quantify it. You can consider an ANA and a DNA and complements, but primarily refer them to nephrology. Cytopenias, as far as a low white count or a platelet count, certainly we can consider autoimmune disease and check your ANA. Remember antiphospholipid syndrome, even if they don't have if they haven't had blood clots or fetal losses or anything, they may have mild decreases in platelets in the range of 80 to 150,000. So if you see that, consider not only the ANA, but also the antiphospholipids and refer to hematology if you find anything there. So the antibodies to blood components are not commonly tested. They're difficult and they're not easy to get, and it's not as reliable. But certainly there are anti-white blood cell platelets antibodies which cause leukopenia. Remember that there are a lot of African American patients who have low white blood cell counts just as part of their genetics. And none of these patients really need significant treatment unless they have recurrent infections. So just the presence of a white count or a low should not be super concerning if they're not having any infections. Again, the antiplatelet antibodies, usually that's ITP and a severe thrombocytopenia, and obviously it's a very serious problem, and hematology manages with steroids and IVIG, splenectomy, all kinds of new drugs that they are using as well. And then the anti-red blood cell, hemolytic anemia, Coombs positive, treat with steroids, all those obviously work with hematology. So fatigue is another very common symptom of our patients, and it's also one that is commonly an ANA is checked. So rarely any autoimmune disease presents only with fatigue. Yes, all of our patients have fatigue, but they usually have many, many other symptoms. That may be the thing the patient is complaining of, but do a very good complete review of symptoms, particularly sleep, fibromyalgia symptoms, and depression. But most of them are multifactorial. Good screening would be CBC and TSH. Don't check the ANA to find a positive ANA. If you don't check it, you won't know that it's slightly positive, but it's not going to help you figure out what's going on with the patient. So just keep that in mind. So Raynaud's is vasospastic episodic cold-induced color changes in the fingertips, white or blue followed by red, but not the fingernails. And so patients will say, oh yes, I have blue fingers in the cold, and they'll point to their fingernails, and that's not Raynaud's. It really has to be the tips of the fingers. I think you should check an ANA in this group of patients. Most commonly, if it's a young person, it is likely to be primary Raynaud's and the ANA is negative. But if it is positive, it may be a sign of an autoimmune disease, whether it's lupus or scleroderma, and we can check for further antibodies. Another helpful hint is that the drugs used, the amphetamine drugs, the ADHD drugs, Adderall, and that whole family of drugs, which a lot of young people are on, often causes Raynaud's, particularly in the toes. And so that's a fun diagnosis to make if you have a new patient with Raynaud's and is on one of those drugs. They often are very relieved, and sometimes they're willing to stop the drug, sometimes they're not, and as long as they know that it's nothing else, but you should still check the ANA in that circumstance. So these are the autoimmune diseases that are commonly associated with positive ANAs, lupus, Sjogren's myositis, and scleroderma. In lupus, the inflammatory features are the joints, and again, it's inflammation, hands, wrists, and knees. It does not have to be swelling, and many of the patients describe swelling, but it can be just arthralgias. But the important thing is it has a inflammatory component of being early morning stiffness. In general, the arthritis in lupus, as hopefully you know, is non-erosive, but it can cause deformities. There's a lot of reducible hyperextension, swan neck deformities, what we call Jacquard's arthropathy, and treatment of that with nonsteroidals, Plaquenil and methotrexate is very common. Another very common inflammatory feature that patients may present with is pleurisy or pericarditis. And again, I've seen several lupus patients that present with fatigue and pleurisy, even though it's not an acute, severe pleurisy, they give you this history of chest pain when they take a deep breath. And so this certainly can be part of an early manifestation, and certainly something you should be checking ANAs for. So the non-specific symptoms of lupus are also very common, but very non-specific. And as I say, the fatigue is very, very common, but it's rarely the only symptoms. Many patients have weight loss with active disease, but again, they're going to have so many other manifestations of their active disease that weight loss is not the primary feature that they're concerned about. Fevers, there's no particular pattern in lupus as far as fevers. They often are early in the disease, and then you once they get treated as far as their on their Plaquenil or nonsteroidals, they rarely ever have it again. But then if they develop it, most of the time it's hard to tell whether there's an infection or whether it's from the disease or from drugs. So again, there's more likely to be other things going on if someone just has a fever, but it's in the young, classic female, young adult, that certainly would be a reason to check ANAs. Mouth ulcers are very difficult management, but they're rarely, again, the primary cause. We had a patient just last week who's had lupus well established, had a few mouth ulcers in the past, had residual Cellcept that she had been using for her lupus nephritis and got very severe ulcers. And we were worried it was from her lupus at first and checked all of her lupus things, and all the lupus things were negative. We held the Cellcept and it went away. Even though she had been on the Cellcept for probably 4 years, for some reason she had a reoccurrence or an exacerbation of a prior symptom, and it was related to drug. Use my telephone here. So the important thing with lupus is that typical clinical findings and laboratory findings are necessary to make the diagnosis of lupus. Here, sorry about that. So when you have someone, if you have a positive ANA or other things, you have to have the clinical symptoms related to that. You have to have both clinical symptoms and laboratory findings of lupus. There are other antibody studies that are also very important in lupus. The anti-DNA, which is very specific for lupus, but it isn't very sensitive. And so it's really only a relatively small number of patients that will have a positive DNA. Sicker patients with kidney disease, with low C3 abnormal urinalysis, you'll find patients like that have positive DNAs. As far as the ENA, the SM, RNP, SSA, and SSB, those are antibodies that we check. Antiphospholipid antibodies are those that we check. RNP is the one that's associated with mixed connective tissue disease, and that's important because many of those Patients will have symptoms of Raynaud's and swollen fingers and early on in their disease, and most of the time they just have lupus symptoms early on. It may have myositis symptoms, but then late in their course, they're more likely to have all the scleroderma ones, particularly the interstitial lung disease, and then even much later, pulmonary arterial hypertension. The antiphospholipid antibodies, of course, increase thrombosis, fetal loss, and neurologic abnormalities, all less common in lupus itself, but certainly can happen. The other ENAs, anti-SM is very specific for lupus, but again, very low sensitivities, and there really aren't a lot of clinical associations. Unlike in scleroderma, where we have specific antibodies that are associated with different findings, the SM is just diagnostic for lupus. I talked about the U1 RNP. The SSA and B is common in Sjogren syndrome when it's present alone, but certainly can be associated with subacute cutaneous lupus, less commonly associated with renal disease, but importantly is associated with neonatal lupus, particularly heart block in babies. And so anytime you have a young person with a positive SSA and B who's about to get pregnant, they need to be evaluated by the high-risk maternity group here. So ANAs, just information about ANAs in lupus in general. Again, we talked about that it's not specific, can be seen in any others. Do not order an ANA unless you have typical symptoms for lupus, if the patient has it. It doesn't correlate with disease activity. So once you have a patient that has lupus, you do not have to reorder it again because it doesn't correlate with activity. And the DNA, those are the things that correlate with the activity of the DNA. I mean, of the lupus. I think we talked about that. The DNA is specific for lupus and correlates mostly with lupus nephritis, can correlate with other aspects of the disease. And it's important to remember that you don't have to have it to make the diagnosis. C3 and C4 correlate with lupus nephritis activity and just activity in lupus in general. The sedimentation rate does not help for lupus activity, and many times we see very active lupus patients that have negative or normal sed rates. In Sjogren syndromes and inflammatory myopathies, different populations, older women with Sjogren's with Zika symptoms and a lot of non-specific symptoms, their ANAs are often positive, and they also have both SSA and B and hypergammaglobulinemia on a serum protein electrophoresis. So that's another clue, something to show that there's something else going on besides just being older with Zika symptoms. Inflammatory myopathies, again, proximal weakness, rarely just pain, increased CPK, aldolase, and then of course associated with a positive EMG and an MRI and a myositis panel, which is a send-out specific set of autoantibodies separate from ANAs. So in Sjogren's and inflammatory myopathies, it's much less sensitivity than in lupus or scleroderma. And so a positive ANA supports the diagnosis, and the presence of the very specific symptoms is helpful, but a negative test does not rule out the disease. So don't fall into that category since so many of the patients have negative ANAs. And then we have scleroderma, and there are lots of antibodies with scleroderma, and 95% of patients, if they have a good immunofluorescent ANA, will have a positive ANA. And then we have these very specific scleroderma antibodies. The most common in the United States are the SCL70 or anti-topoisomerase the anti-centromere, and the anti-RNA Polymerase III. You see this U1RNP, which is an overlap, and these patients can have pure lupus, pure scleroderma, pure myositis, or they have an overlap with all of them. So they're only mixed connective tissue disease if they have both the antibody and the overlap of one or another, of two connective tissue diseases. If they just have one disease and the antibody, they have that disease. And then these other antibodies, THTO, U3RNP, and PMSCL, are nucleolar pattern ANAs. And so that's very helpful. We're just now getting a scleroderma big panel that we can get these other antibodies in. So that's quite exciting, because up until recently, they hadn't been available. Antibodies are very helpful in characterizing the disease. The anti-centromere antibodies is the centromere pattern, and this is the classic limited scleroderma with long-standing Raynaud's, puffy fingers, but they rarely ever get extensive skin involvement. They get lots of vascular problems, lots of GI problems. Some of the worst GI problems that we see happen in centromere patients. And also they're at a very high risk for pulmonary arterial hypertension, and that's associated with a very low DLCO. They are at low risk for having pulmonary fibrosis, very low risk for having renal crisis, and a relatively low risk just because heart disease in general is uncommon, but it's also less common in limited scleroderma with centromere antibody. The anti-topoisomerase is the classic diffuse scleroderma, although it's important to remember that a third of them actually have only limited cutaneous disease, and this group of patients is at high risk for having pulmonary fibrosis. They have the most severe pulmonary fibrosis of all the scleroderma patients, but they are also at high risk for heart and kidney involvement. And then there's the anti-RNA Polymerase III, which is most associated with severe diffuse cutaneous disease, a very high risk for renal crisis. They actually have some fibrosis, but surprisingly, in spite of the severe skin fibrosis that they don't have as frequently have severe pulmonary fibrosis. And interestingly, they have this unique association with malignancy. It's not really what I would call a paraneoplastic, because I think of that as more of the disease going away when you get rid of the cancer. This is an association with the antigen. The antigens, the polymerase III antigens, are actually seen in the malignancy, and then there's a fancy immune system mechanism that causes the antibody, and then somehow or another the disease develops. But it's really, we found by making the diagnosis of scleroderma with this antibody, I think in the past year I've diagnosed 3 totally unknown malignancies, and they were very early stage and probably are cured from their malignancies. And then the other unique, not totally unique, but is much more common in RNA polymerase III is watermelon stomach or gastric antral vascular ectasias, which is the silent bleeding in the stomach, which the patients present with severe anemias. This is also seen in late anti-centromere antibody patients, but it's a very problematic problem in our patients. But it's important, particularly in this group, because it's early disease. So in conclusion, I think it's very important that ANA should not be performed without a clinical evaluation that suggests a connective tissue disease. Symptoms that would be suggestive of lupus, scleroderma, Sjogren's, myositis, or Raynaud's. The ANA testings have an extremely low specificity and positive predictive value in the general population. And many diseases may cause positive ANAs, and many healthy individuals have positive ANAs. So not everybody with a positive ANA is going to come up with a disease that you're going to do anything about. So if you focus on ordering ANAs on ones that are the diseases that you can do something about, that will, I think, in the long run be helpful for both you and the patients in not getting confused and go along a lot of other different tracks.